This is why.
I'm Dr. Ilham Youssef. I'm the Vice President of Medical Affairs and Associate Chief Medical Officer at Tampa General Hospital. I'm also an Associate Professor of Medicine. I'm still actually waiting for my credentials here with the University of College Medicine. And I am an internist and hospitalist. And it's really my pleasure today to introduce one of our national experts in perioperative medicine, Dr. Manjarrez. He's an associate professor of medicine, and he is the founder of the Department of Medicine at the University of Miami Miller School of Medicine in 2001. He graduated from the University of California School of Medicine in San Diego, and then he completed a combined internal medicine and pediatric medicine at the University of Miami Jackson Memorial Hospital. He is the former chief of the Division of Hospital Medicine at the University of Miami Miller School of Medicine. He also served at the University of Miami Health System in different roles. Most importantly, he was the Associate Chief Quality and Safety Officer for UHealth, Patient Safety Officer for now MCI designated Sylvester Comprehensive Cancer Center, which was recognized with a Health Grade Award for patient safety during his tenure. He lastly was the Associate Chief Medical Officer for the University of Miami Hospital. Nationally, he is the course director for the Flagship Society of Hospital Medicine annual meeting in 2015 for over 3,000 hospitalists who attended that year. He received the Society of Hospital Medicine Award of Excellence for Outstanding Service for Hospital Medicine in 2020, and he is currently serving on the Society of Hospital Medicine Board of Directors. His professional interest, as you see from the title, is perioperative medicine, in addition to quality improvement, transition of care, leadership, and medical education. It's my greatest pleasure to introduce Dr. Behnke.
Thank you so much. Thank you very much. And I guess for that introduction, this better be good, huh? Well, it's really, really great to be here. Being down south, I've always had so many questions and curiosity about USF. So thank you so much for inviting me, Dr. Sinet, Dr. Youssef, and of course my new friends. I would like to dedicate this particular lecture to the USF hospitalists, which I'm going to get a chance to meet later today. So my strategy is, with you guys today is to sort of walk you through what are some of the things that we know about perioperative medicine. And then, of course, I'm going to give you some updates. What's recent in the last few years that I think are game changers. Yeah? So, moving forward. I was told to pick 3 learning objectives, but I really have more than that. So I'm going to talk about some risk calculators for the management of cirrhosis. We're going to talk about something called MIN. A lot of attendings when I speak either at Society of Hospital Medicine or ACP, they're like, what is MIN? And of course, we'll talk a little bit about the management of direct oral anticoagulants, among other things. Okay, so the background to this, the needs assessment, this is my QI hat, using a QI term. The needs assessment is that there's millions of patients around the world that undergo non-cardiac surgery around the world every year. And despite all of our advances in surgical technique, our advances in anesthesia and advantages and updates and risk stratifications, unfortunately, patients still have bad outcomes. And so, what can we do about that? Obviously, this is my passion. So, let's talk about first and foremost, how do outpatient and inpatient internists, hospitalists, identify patients at highest risk for perioperative complications? Let's talk about cirrhosis. Let's talk about cardiac risk predictors. Let's talk about functional capacity and the updates there. Let's talk about the pulmonary piece and then obstructive sleep apnea, something that I had a hand in writing for Society of Hospital Medicine. So let's start with a case. You have a 55-year-old patient with a second episode of biliary colic You want to send the patient to the OR in the setting of alcoholic cirrhosis. You can see the labs there. The patient doesn't have ascites, but you can clearly see that the patient has got significantly advanced cirrhosis, right? Guy's a little confused. What to do? Which model, which risk predictor do you use to predict post-operative death in 30 and 90 days? Is it vocal pen, Mayo, MELD, or MELD sodium, or just called hepatology? MELD, somebody says. Okay, so let me tell you why I think you should consider using vocal pen. Background to this, of course, is that we've known for some time that cirrhosis is a very, very deadly disease, and it confers significant perioperative risk. And so the question is, which risk prediction tool is the best to guide care? So in this particular study, the vocal pen score was being compared to 3 other scores: Mayo, MELD, and the MELD sodium, in 2 large health systems of New York. Almost 1,000 patients looking at these different statistics. Anything in this picture? Oh, good. So you don't have to correct me on statistics. All right. So what do these scores tell you, first of all, right? Many of us use MELD in daily practice, right? MELD and MELD sodium. The Mayo score is pretty much the MELD score plus a few other parameters. They use the cause of cirrhosis as alcohol. Whereas vocal pen is a bit different. It uses the bilirubin and then all these other clinical predictors, and they use NASH as their cause of cirrhosis, which I'll explain to you later. And they also actually take into consideration how emergent is the surgery and what is the surgery type. Not all surgery is the same, right? A breast biopsy is much different than, let's say, a right hip fracture, right? Total hip arthroplasty. So, as you look at this, on the top 2 graphs, you're looking at the discrimination. How do the scores predict death versus being alive at 30 and 90 days, A and B? They perform fairly similarly. Vocal pen had a higher statistic at about 0.64. Mayo was up there as well, but vocal pen was just, slightly a little bit better. But then when you look at the calibration is actually what's the observed versus the expected. And as you look at the red line graphs, it suggests that the Mayo score over predicts bad outcomes. Now, if you're a frontline clinician, if you're in the preoperative clinic, or if you're a hospitalist and you're trying to assess risk for the patient, that might actually cause you to not send the patient to the operating room. So, at the end of the day, and this is just another different way of showing that particular data, will this actually dissuade you from sending your patient to the operating room? So at the end of the day, most of these patients were Child's Class A patients, but there was good prediction for the higher MELD scores. As you guys know, NASH correlates with other predictors like diabetes and cardiovascular disease. And so also platelet count was a big surrogate for portal hypertension. It was less than 10 variables, so it's pretty user-friendly on your phone. You can use this on your calculator, just like you do your other scores that you use. And so the authors suggested that as care improves over time, all predictors will get worse. As the example was the Mayo score, which uses alcoholic cirrhosis as the major cause. But now we're seeing a lot more fatty liver as causing cirrhosis. So food for thought. Okay, so now let's change topics for a moment. Talk about the cardiac piece. Cardiac. Has everybody seems to think the only thing that matters perioperatively is the cardiac piece? How many cardiologists that are budding in the audience here? Right? Everybody's like, it's all the heart, right? So as you guys look and you see what's the algorithm that the American College of Cardiology proposed in 2014, is it an emergency? No. If it's an emergency, go to the OR. If not, step 2, are they having an acute coronary syndrome? If not, then go to step 3. Step 3 is, what is the risk of MACE, major adverse cardiac events? This is where a lot of people get stuck. This is where a lot of people start to think, so let me talk to you about 3 predictors. So we have the Leeds revised cardiac risk data. This is done in about 2,000 patients about 22 years ago. And you can see that it performs pretty well. The C statistic was 0.76 to 0.8. Low risk scores versus intermediate risk scores versus high risk scores. And the variables are this high risk surgery, coronary disease, heart failure, creatinine of 2 or more, history of stroke, or insulin. Notice I didn't say chronic kidney disease. Specifically, the metric is a creatinine above 2. And notice I didn't say diabetic. The metric is specifically being on insulin. So this is really the one that most people use because it's really easy to memorize. It's pretty lickety split. If you get 2 points or above, you're considered high risk. There's also the NISQIP. And the NISQIP is really emerged as probably the more common risk prediction tool. You go into this website or on your phone and you punch in these 21 specific factors on your patient. Usually there's drop-down menus there to help you and make it easier and user-friendly for you. And then it calculates the risk of major adverse cardiac events and death and all these other things. And so in this particular example, I don't know how it shows very well, but this is a 78-year-old patient who's going for lower extremity vascular surgery and vascularization in a setting of hypertension, heart failure, and dialysis. And you can see that the outcomes are predicted to be very, very complicated. Very complicated. You might want to rethink sending the patient to surgery. Or at least the patient has adequate consent. I wanted to share with you a new risk prediction tool that's come out called the American University of Beirut HAS2 score. And actually, if anybody is a member of the Society of Hospital Medicine, our special interest in perioperative medicine, about 2 weeks ago, we actually had a journal club with Dr. Behnke, who joined us live from Beirut. It must have been about 2 o'clock in the morning for him. And subsequently, they looked at their own internal patients and they validated it with the NISQIP database. And so this particular, what happened? Sure. You good? Better. So the HAS2 score is basically history of heart disease, symptoms of heart disease, which are not only chest pain, but also dyspnea, age or anemia, or the type of surgery, being vascular emergency surgery. The reason I bring this up is because the American College of Cardiology is going to be coming out with their new risk algorithm. Since 2014. It's either going to come out at the end of 2023 or at the beginning of 24. And the European Society of Cardiology just came out with their guidelines in the last couple of months, and they mentioned this as one of the acceptable risk predictors. You may see this with our own American College of Cardiology guidelines. And this is how it performed in different surgeries. You can see every single type of surgery. The high-risk patients are in blue with a score of 3 or above. Intermediate risk is, I think it's a score of 2 or 3. High risk is more than 3, and then low risk is 0 to 1. And you can see that in all these different surgeries in a dose-response relationship, as your points go up, it actually works. It's actually got a receiver operating curve statistic of about 0.9, which is really, really good for the epidemiologists in the room. So okay, so let's just say your patient has low risk. Then the patient has an elevated risk. You go to step 5, which is the functional capacity. How many of you guys just keep thinking the 4 METs, right? The 4 METs, the 4 METs, the 4 METs. Can they walk 2 flights of stairs or 4 blocks at a moderate pace, right? So, well, they're there as well. So let me give you, So you have a 71-year-old going for colorectal surgery, coronary disease, hypertension, diabetes, on insulin. Right away, you can see the revised cardiac risk index is elevated. No chest pain, lifestyle. You can see the creatinine. They always have that EKG with non-specific T-wave changes, right? Everybody has those? Okay. So what's your next step? For your subjective assessment, she could probably do 4 METs. Go to the OR. Get a hemoglobin A1C. Stress her like the guidelines say and be done with it. Those people at Duke know a little something about functional capacity. So that's actually the answer, sort of. Let's talk about this. So we're going to talk about the METS score. Is there any way I can get rid of that black bar up there for my IT friend? This is the METS study. The background to this is, of course, everybody thinks 4 METS, 4 METS, 4 METS, right? The question is realistically, Dr. Dhuminder Vayasundara in Toronto, an anesthesiologist, looked at this. He says, you know, are we really very good at predicting 4 METS, or are we generous with our patients? They could probably do 4 METS, send them to the OR. So the truth was, that was the research question, is how good are physicians, in this case anesthesiologists, at really assessing the functional capacity of their patients. They compared this with something called cardiopulmonary exercise testing, the DASI score, and then a preoperative BNP. And if it was above 300, it was considered to be at higher risk. 1,400 patients, short-term and long-term death, and other complications. That's cardiopulmonary exercise testing. Bike ride in the office. So here's the DASI score. Have any of you guys seen it? Some of you guys? So as you look at all those, there's 12 questions. You get 58 points. I think the average for the cohort was about 42 points. Can you do all these different things? Unfortunately, my wife dinged me on something there. I know what you guys are thinking. She said, I don't do that much housework. So when they tested these people on the bicycle, they found that the anesthesiologists, when they rated the patients, they said 93% of the cohort of 1,400 can do 4 METs and above. But when they tested them, there was almost 19% that couldn't. What are the implications of that? The implications are that we're correctly picking up about 81% that are able to do on the bike 4 METs. In the peak oxygen consumption of 14 is actually about 5 METs. But the truth is that it wasn't 7% that couldn't do the 4 METs. It was like 19%. And that has implications because we're missing 19% of those patients that were generously saying they can go to surgery. So at the end of the day, the subjective assessment didn't quite match up. There was no association with the study outcomes, which is short and long-term mortality. But there were other complications that were actually associated with poor performance on the bicycle. And you can see that none of these were cardiac, interestingly. So this was really a very interesting study. The major findings suggest that we shouldn't be using functional capacity, subjective assessment. And as the new ACC guidelines are coming out, I'm kind of wondering if they're going to ask us to do the DASI score and have your patients fill this out, either in clinic, you know, pre-op clinic, or if you're on the floor as a hospitalist, you can tabulate it on your phone. But the DASI score, a high DASI score, was actually protective for patients, short and long term. Elevated pro-BNP of 300 or above was actually a risk for bad outcomes. And so, of course, they suggested a more objective assessment of functional capacity for the patients. Because again, subjective assessment did a bad job. Now, there were some limitations of the study, full disclosure. They weren't a very high-risk group of patients, and they weren't going for high-risk surgery. So in my mind, as I look at this, and as a clinician educator who reads these papers, I ask myself, is it really under-predicting, you know, events? But the truth is that we're not doing a good job of functional capacity assessment. At the end of the day, the highest risk, where they found the highest risk, was a DASI score of less than 34. But like a third of the patients had a DASI score of less than 34, which of course has other implications. So these were at risk for all these other complications. And the lower your DASI score by each number going down, you actually increase your odds ratio for bad outcomes perioperatively. So what about heart failure? Because everybody's always thinking coronary, right? But you know, the transplant cardiologists are like, hey, give us some love, right? What's going on with heart failure perioperatively? Well, this was a very interesting paper in JAMA just a couple of years ago. And as we know, heart failure is a risk factor for perioperative events. And so the research question in this paper was, excuse me, what was the relationship between ejection fraction and perioperative events at 30 days?
large retrospective cohort in the VA. And of course, your outcomes here were 90 days, 90 days. And about 8% of these patients actually hit the outcome. So as you look at this, you say, wow, patients with heart failure, look at their odds ratio, any heart failure, diastolic, preserved ejection fraction, or otherwise. And then in a dose-response relationship, the worse your ejection fraction, the worse your perioperative events. And of course, even if they were asymptomatic, they had outcomes. But if they were symptomatic, it was that much worse. So heart failure is also a bad issue. And it's something that we have to keep in mind, not just the coronary piece. All right, let's switch topics again. Let's talk about the pulmonary piece. So the background is I had more slides on pulmonary, but I know I have a lot of slides, so I want to make sure I'm finishing on time. The most important part of the perioperative pulmonary risk assessment is where is the surgery? High abdominal or thoracic surgeries result in painful bleeding, particularly if there's large scars, inefficient and painful breathing. And if you're a patient who has decreased pulmonary reserve, like say, for example, my father-in-law who's got interstitial lung disease, then those patients perioperatively can get into bad outcomes. With respect to clinical risk factors, most people think it's COPD, but it's actually age and American Society of Anesthesia score. So that's why, you know, for the pulmonary piece, if you have a patient with decreased pulmonary reserve, you actually want to suggest to the surgeon, you know, if possible, please keep this laparoscopic, you know, to protect the pulmonary outcomes, and lower abdominal, of course. These are the risk predictors. The one that's pretty common, anybody been to Barcelona? One. So if you want to do academic medicine in Barcelona, Dr. Canet, I'm sure, is looking for fellows. So he did a perioperative pulmonary complications and did a derivation and validation looking at 100% of patients in the community of Catalonia in Spain. And this is what he came up with. Age, preoperative room air saturation, a recent respiratory infection or COPD exacerbation. There's our location of surgery, prolonged surgeries, emergency surgeries, and anemia. And so as you get these points, then you can go into pulmonary complications, which are defined as pneumonia, COPD exacerbation, hypoxia, and they even call atelectasis, which I don't understand that piece. But at any rate, and then for respiratory failure, he did this one called Periscope. And these are actually available on your phone as well. So you can find these on your phone. And at the end of the day, there's other risk predictors. The NISQIP has one, as does Dr. Gupta, who does this. And it's the same clinical predictors at all the clinical predictors. Advanced age, the location of the surgery, the functional status, the duration of surgery, emergency surgery, and then respiratory symptoms or COPD exacerbations and desaturation. So even if you don't download these risk predictors, you can just remember those 6 factors. Now, how do we optimize, you know, the lungs? I mean, all these different things. But to be honest with you, how much of these things are things that we're doing as internists and hospitalists? Well, I'm going to show you downstream in the lecture what's enhanced recovery after surgery pathways, ERAS pathways, which my friend Dr. Yusuf is well aware of as the chief medical officer for those quality metrics, postoperative CPAP for those patients that are getting into trouble, and of course, chest physiotherapy, respiratory physiotherapy. But there were all these other things that got voted off the island in this meta-analysis that didn't quite meet strong evidence, believe it or not. Even postoperative BiPAP and high-flow nasal cannula, which was very surprising. Even smoking cessation. I mean, who would say that inhaled beta agonists aren't going to be having efficacy in terms of preventing and treating postoperative pulmonary complications? So go figure. Dr. Oder published this. Okay, so this is my transition to another space, a space that's near and dear to my heart. Let's talk about sleep apnea. How do you make the diagnosis of sleep apnea at the bedside? Well, here's our friend David, who came to visit. I know all the girls are like, but David, he's so beautiful, right? Not after a few years in America having our diet and our sedentary lifestyle. So, but how do you make the diagnosis of sleep apnea at the bedside? Well, there's a stop bank score. The stop bank score, along with the Berlin score, the stop score, there's now also the B-apneic score, and then there's the Boston bundle has another one, but the most well-studied and validated internally and externally from Toronto, stop bank score. 3 symptoms. And I don't ask this to the patient, because the patient oftentimes can't tell me, but, I'll say to the spouse, does he snore? Oh, yes, like a choo-choo train. My wife used to say that about me. Are you sleepy during the daytime? Or you take naps? And then the last one is, does he choke at night? Oh, yes, it's scary. And the patient's looking like, really? I'm choking in the middle of the night? Oh, yes. And then, of course, these 5 other objective findings: blood pressure, BMI, age, neck circumference, and gender. And so there's also something called the Mallampati score. And the Mallampati score is when you're looking at the airway. Now, when you're doing the Mallampati score, you have the patient tilt their head back and stick out their tongue. And you look at the airway. You don't tell them to say, ah, because as you guys know, particularly the pulmonary folks, when you're intubating somebody, the patient doesn't say, ah, so you can stick the scope there, right? They're paralyzed, right? So they just stick their tongue out, and that's what the anesthesiologist sees when they're intubating the patient. If the uvula is high above the tongue, it's a Mallampati score of 1, and if your airway is obstructed entirely, that's a 4. And those patients are more likely to have sleep apnea. But the stop-bang score of 5, that's really the magic number when patients present to surgery. When patients present to general surgery, up to 25% of them are undiagnosed sleep apnea, believe it or not. And we take care of those patients on the wards, right? We take care of, how many times you guys are in the wards and you're sending the patient to the OR, right? All the time. So, you've got to have that index of suspicion that this patient might have sleep apnea and they can get into trouble post-operatively. But if they don't have a stop-bang score of 5 and they don't have their stop-bang score is 0 to 2, it's a low risk. If it's a stop-bang score of 3 to 4, then you can go to a next step and say, okay, if their stop score is 2 or above and they're either male, heavy, or a large neck, then they also have a high likelihood. And this is from Dr. Francis Chung, who's in Toronto, who's really the content expert in perioperative sleep apnea. Why does this matter? Why are we screening for these complications? Because Dr. Opper and colleagues 6 years ago did this study, a systematic review looking at the impact of perioperative sleep apnea. This is actually something I wrote about in a CME module. And so you see these patients have desaturation, they're difficult intubation for the anesthesiologist, and postoperative pulmonary complications. They also get atrial fibrillation as they do in the ambulatory setting, and they also take up a lot more resources. So that's why it's important that we don't miss sleep apnea going into the operating room. They're going to have more likely longer lengths of stay. Fortunately, none of the studies that I've seen have shown mortality, but this is actually relatively new. This was looking at cardiac events, and the long story short on this is that patients with severe sleep apnea have bad cardiac events, not mild to moderate, severe sleep apnea. And this was the first time I had seen this looking at the data. And so here's some other complications. Now, not only with non-cardiac surgery, but with cardiac surgery, they're getting into trouble, as you see the scatter plots there. And then if you look at other types of surgeries, and this is a good size study as well, look at cardiovascular complications now we're starting to see. Hospital and ICU admission with sleep apnea, and of course now neurologic complications. So this was actually relatively new data. But fortunately, the mortality piece, we don't see mortality. We just see more resource utilization and complications. Dr. Chung and colleagues, the Society of Anesthesia and Sleep Medicine published their guidelines a few years ago. What they'd like you to do is the sleep studies and get the sleep studies, and then tell patients to bring their device and put it on them in the recovery room. And this is particularly important for outpatient surgeries, because outpatient surgeries, who's going to monitor them for the next 24 to 48 hours? And that's when they're going to get into trouble, 24 to 48 hours. You can document that they have sleep apnea on your diagnosis and on your pre-op consult, or you can actually document it's an ICD-10 diagnosis, suspected sleep apnea. And I do that at perioperative clinic when I have a patient who's got a stop-bang score of 5. Then I'll put it in there, this patient's suspected sleep apnea. And that way it alerts the anesthesiologist, what's coming their way. And in this way, the anesthesiologist knows to plan for a difficult intubation and possibly bag mask ventilation. What are the red flags for sleep apnea? Well, you guys have all heard of obesity hypoventilation syndrome, right? And so these are really the patients that have, if you're looking, they've got chronic pulmonary disease, or in this case, sleep apnea, and they've got a serum bicarbonate level of 28 or above on their BMP, and they're not on diuretics. So that's sort of like the hemoglobin A1C of sleep apnea is the serum bicarb and the BMP. Those are the red flags that you sort of need to refer them to sleep medicine before elective surgery. Patients with severe pulmonary hypertension. This is a whole nother set of slides that I could give you. Hypoxemia that you can't explain otherwise. Those are the patients that are red flags that you need to send to sleep medicine beforehand. Other things, postoperatively, minimize sedatives and opioids. Your anesthesiologist will be wanting to do their surgery under blocks and regional anesthesia. On our end, on the medicine end, putting them on continuous pulse oximetry postoperatively, starting from the recovery room. Supplemental oxygen as needed, and of course keep the patient, in a non-supine position, so they don't aspirate. They can guard their airways. Continue their positive airway pressure at their known settings, and if they're getting into trouble, start them on CPAP postoperatively. Whatever you do, don't give them lots of opioids. These are patients that already have blocked airway, and then if you give them opioids, you're going to blunt their respiratory drive, and that's a recipe for failure. Okay, now what's the biggest innovation or the biggest change in the last few years? Perioperatively, it's biomarkers. Lecture talking about biomarkers. So the background to shown and talked about is that perioperative cardiac events are there, and they're related to the patient's preoperative clinical risk, related to their cardiac risk. And so perioperative mortality, MI, and major adverse events, stroke, the rate isn't that high, but 3% is there. Now, if you tell an anesthesiologist, 1 in every 30 patients that you're going to put to sleep this week is going to have some sort of a bad outcome, they get a little nervous about that, particularly in outpatient surgical centers. But now we have biomarkers that have emerged as an adjunct to our risk prediction. Problem has been that we don't have clear guidelines in terms of how to use the biomarkers. Let's go through this as I teach you about this. Well, if we just go back to just what is myocardial injury, right? In the center, of course, is clear evidence of an acute MI, right? So they've got an elevated troponin plus either, chest pain, EKG, stress test, cath findings, or at autopsy. And then, of course, you start going out to the lighter color where you've got myocardial injury. And perioperatively, that's where the science has been going, is that we've been seeing this, but we didn't quite know what to do with it, how to diagnose this, and so forth. And that's really where the perioperative space has emerged lately. And then in the blue, you see all these different areas where you've got these causes, let's say, of maybe type 2 MIs or elevated troponins. So this was the first study to actually look at this. They looked at troponins in patients who were spilling troponins postoperatively. And as you can see here, if the troponin T was at 0.30, the 30-day mortality was 1 in 6. This is, my friends, MINS, myocardial injury after non-cardiac surgery. Now, myocardial injury can also be an acute MI, but about 80 to 85% of these patients don't meet the classical definition that I showed you before of a clear-cut MI. It's basically this right here. They're spilling troponins. Now, why are they not having symptoms? Because our anesthesiologists have them intubated, they're sedated, they're under the effects of opioids, they have altered mental status, they're comatose, any number of reasons, but they don't have chest pain, and they don't have a clear-cut EKG findings, but they're spilling troponins, and they're at risk. And Vision 10 years ago was the first ones to tell us this, from PJ Devereaux's group in Canada. In the same group, Dr. Emmanuel Giuseppe looked at preoperative troponins and sort of, looking at preoperative troponins and then screening those patients for a few days later to see, does this add value to the revised cardiac risk index? I'm not going to show you the RCRI data, but I'm going to show you specifically what happened when the BNPs were elevated. And at the end of the day, in a dose-response relationship, the higher your preoperative BNPs, the higher you either had MINs or you had mortality at 30 days. I'm going to tell you that 90% of these patients plus were MINs. They weren't mortality. But the point was they weren't having clear-cut negative outcomes. They were having bad outcomes. And the MINs patients downstream, they get into trouble. Zhang and colleagues looked at biomarkers in this systematic review and meta-analysis 3 years ago, looking at BNPs, and you can see that whichever BNP you use, if it's elevated, I mean, look at the scatter plots. Stevie Wonder could see that. And the same thing with troponins. The elevated troponins also do this. So preoperatively elevated BNPs, postoperatively elevated troponins is sort of a recipe for negative outcomes. So as we go through MINs, what's the definition? It's this troponin rise after non-cardiac surgery, usually occurs in the first 72 hours. And they don't quite meet the clear-cut definition for an MI. It's typically like a type 2 MI, not due to a non-ischemic cause like PE or sepsis or AFib or chronic elevation of troponins from renal failure. It's sort of, there's some non-critical coronary disease that just got sort of exposed in the surgical time frame. It's older men, usually, with urgent procedures, and they either have known coronary disease or significant risk factors. But the new risk factors, AFib, diabetes, the stop-bang score from Dr. Chun's work, the DASI score from Dr. Vayasunda's work, and the frequency depends on how sensitive your biomarker is. So for high sensitivity cardiac troponin, it's higher. And for the lower sensitivity troponin T, it's a little bit lower. So you have to have that index of suspicion. Who is going to have MINs? Who do I need to screen, and so forth? As I mentioned, we didn't have guidelines what to do with this. The Canadians a few years ago, they actually started screening people with a preoperative troponin, BNP of 300, which is interesting because I think Dr. Giuseppe's work showed a rise after 200, but 300. And they suggested screening these patients postoperatively. So our own American Heart Association, a year ago, I want to say this paper was published a year ago today, came out and they basically gave us in medicine and cardiology guidelines. And they said basically the definition I just gave you before. And they said essentially if your troponins rise or they fall or both, 20% or these thresholds, you've got the diagnosis of MINs. You've got the diagnosis of MINs. Now, so I was mentioning that myocardial injury can come in different flavors. There's, on the left in the red, there's a clear-cut MI. And of course, you'd manage those as you would any other MI, calling cardiology and cath lab and, dual antiplatelet therapy and statins and beta blockers and so forth. But if it's MINs, then, unfortunately, we don't have great treatment strategies. The managed trial looked at dabigatran a couple of years ago, and it was flawed. They didn't have enough events when they were looking at cardiac events, so they added venous thrombosis events to sort of power the study better. There were some benefits with dabigatran, but as you can see here, the American Heart Association says consider antithrombotic therapy. They didn't clearly say use dabigatran or use another direct oral anticoagulant. So we really do have no clear-cut strategy. MINs at this point is really for prognosis. What are you supposed to do? What does our American Heart say? For patients 65 and above who have a high clinical risk, and for me, that's a revised cardiac risk index of 2 points or more, then you're supposed to screen them, getting preoperative troponins, and then repeating them post-op. And if they're a younger patient with known coronary disease, do the same thing. And again, a rise or fall of 20% in those biomarkers, and you've got your diagnosis. And what are you supposed to do? Call cardiology for individualized treatment. Intensify your cardiac medicines, they said in the paper. Beta blockers, antiplatelet agents, statins, and ACEs and ARBs. This recommendation was based on a very small study of less than 200 patients in France, where they showed that the patients who had medication intensification, actually their hazard ratio dropped to like 0.66 versus those patients that didn't. So obviously that study needs to be escalated and upsized and tried in multiple settings in a randomized trial. So that's why they don't have a clear-cut intensification recommendation. Surveillance with cardiology, and of course lifestyle modification, as we should be doing anyways, because these patients have a short and long-term adverse prognosis. So the take-home points: 4% of the time, perioperative myocardial injury is asymptomatic, but we do have biomarkers to help us make that diagnosis. Remember that MINS is one level of myocardial injury, right? The spectrum which I've shown you, but it's currently, this diagnosis is for prognosis. And of course, the optimal treatment is a work in progress right now, and call your cardiologist. So that's MINS. Now let's move forward. Oh, we've got another case. How about that? It's Thursday morning. It still is Thursday morning, right? And you have a 75-year-old lady with a CHADS-2 score of 4 and has non-valvular AFib, lower GI bleed on dabigatran for stroke prophylaxis, and colonoscopy shows non-metastatic colorectal mass. Colorectal surgery calls you and says, hey, I'm taking this patient to the OR on Monday. What are you supposed to do with the dabigatran? Stop it 4 days before surgery and restart it post-operative day 2? Oh, let me just go back here. The creatinine clearance was 45 and she had no history of a prior stroke. Important for you. Stop the dabigatran 4 days pre-op and restart post-op day 2. Stopping at 4 days before surgery and starting low molecular weight heparin 3 days before surgery. The last dose the day before surgery, and then restart the DOAC 2 days later. The last dose is Friday evening and restart on post-operative day 2, or Saturday evening and restart on post-op day 1, or just call hematology. Any thoughts? B, he says. We've got a bridger there. Okay, so let's talk about this paper by Dr. Duquetis called the PAUSE. It's not a trial, it's a study, because it wasn't a randomized trial, so I have to change the slide. So the background to this is that management of non-valvular atrial fibrillation preoperatively on DOACs was unclear. And so the question from Dr. Duquetis, also in Canada, is there a protocol that works for this? This is a prospective cohort study, international study of 3,000 patients on the 3 DOACs listed there. And the outcomes, of course, whenever you're doing a study on blood thinners is what? Thrombosis versus bleed, right? Thrombosis versus bleed. But they also looked at undetectable or minimal residual anticoagulant levels. I'm not going to show you that data other than to tell you that there was no blood thinner on the day of surgery. So here's the protocol. It's pretty simple. If you're taking your patient for, well, first of all, they defined high bleeding risk surgery versus a low bleeding risk surgery. High bleeding risk, hip arthroplasty, colorectal mass resection, vascular surgeries, right? Low risk surgery, things like interventional radiology procedures, biopsies, maybe a breast surgery, that. And so they said for the 3 direct oral anticoagulants, if it's a high bleeding risk, stop your direct oral anticoagulant, hold it 2 days pre-op plus the day of surgery, and then restart on post-operative day 2. If it's low bleeding risk, then it's pre-op day 1 and post-op day 1. But the kicker was, because of the clearance of dabigatran by the kidney, if your creatinine clearance was low and they're on dabigatran, which is why I came back to tell you guys that, you're supposed to double those days. So 4 and 2 as opposed to 2 and 1. So it's pretty simple, and in fact, the outcomes were actually pretty good. The thrombosis and the bleeding rates at 30 days were very low. Now, if you've read those blood thinner trials, the CHAD score is actually pretty low. It's only a 2, right? Which is pretty similar to, oh boy, apixaban was Aristotle, dabigatran was Rely, but rivaroxaban was Rocket, and they had a higher CHAD score. It's still similar. At any rate, the death rate and everything else was very, very low. And unlike the bridge trial, where the CHAD score, higher CHAD score might result in higher worsened outcomes, they didn't see that here. They didn't see that here. So that was kind of reassuring. Take-home points. Don't bridge DOACs. My bridger over there, don't bridge DOACs. You just let them fall off, stop them, you'll do fine. For high bleeding risk surgeries, 2 days pre-op and 2 days post-op. For dabigatran and low creatinine clearance, then double it. And thankfully, the bleeding and thrombosis rates were low. All right. What's ERAS, you say? This is what your surgeons are doing, whichever surgeons that you're working with. These bundles are shown to reduce perioperative complications, reduce length of stay, and better outcomes. And they have these big components to it. What's prehab? You guys have heard that one before? Prehab is sending them to rehabilitation PT before surgery to improve their functional capacity. That's prehab. And then these other things. I don't know about loading with carbohydrates. I don't know how they're doing that. I guess I'll leave that to the surgeons. What are the things that we do as internists? This is the ortho bundles. And for internists and hospitalists, the things in blue are the things that we do, right? Get them up out of bed, making sure they're on appropriate DVT prophylaxis, smoking cessation, alcohol cessation, correcting anemia. I think you guys are going to get Dr. Audon to talk about that pretty soon, our friend from Cleveland Clinic. And then, so all these other things. And then there's other things that anesthesia does, right? There's other things that anesthesia does. But this is what your surgeons are doing. And if you're seeing standardized order sets, this is what they should be doing in order to improve your outcomes. Now, the last couple of minutes of this talk, I want to share with you an article called Give Them What They Want. Give Anesthesiologists What They Want by my former chairman of anesthesia, David Lubarsky, and my current chairman of anesthesia, Keith Candiotti. And this article that was published 12 years ago is what I like to end my talks with in perioperative medicine. So let's talk about, think about the anesthesiologist as your customer, not just the surgeon who's referring the case to you. Because it's the anesthesiologist isn't doing the surgery, but as Keith Candiotti tells me, he says, Efren, I'm not canceling surgery, I'm just canceling anesthesia. So you have to make sure that we, as internal medicine and hospitalists, might say the patient may proceed to surgery without further testing, but the anesthesiologist will still refuse to put him to sleep, right? So what does the anesthesiologist know? They know vents. They know anesthetics. You guys remember Dog Lab from medical school, right? The cardiac and pulmonary physiology, they know that stuff, right? They know where to send the patient out, where they can go home, or they can go to the ICU or the floor. And of course, again, cardiovascular and respiratory physiology, that Dog Lab stuff. That's what they know. Now, where do they need our help? Where do they need our help? Well, how to optimize the function of an unhealthy organ system. Don't forget that your anesthesiologists are not medicine like we are. They don't do chronic disease management. They don't do that. They do insulin drips. They don't do metformin. They don't do empagliflozin. They don't do the injectables. They do drips. That's all they do. And I don't say that to demean them. What I'm saying is they've got their scope of practice and we have ours, right? So how do you optimize the function of an unhealthy organ system? They want us to tell them how to manage their pills. What am I supposed to do with the beta blockers when the patient comes? What do we do with the ACE inhibitors? What am I supposed to do with their blood thinners or their thyroid medicines? Because they're not used to titrating medicines unless they do pain medicine, right? In which case they're doing all the opioids. If you put in your plan in place to optimize an unhealthy organ system, how long is it going to take to get the patient optimized? Now, if you're in pre-op clinic or you're in primary care, you might have some time. But if you're the hospitalist, you might not have time. And so you need to put on your note, look, this is as good as it gets. Or you know what, the patient's wheezing, I need to give them, steroids and bronchodilators, for 12 hours, and then by the morning they should be okay to go, right? But tell them how long until the patient's optimized, or if you can't get them any better, So for example, my father-in-law who needs to get CABG surgery, he's got interstitial lung disease. I don't know that we can get him much better, right? And so the anesthesiologist needs to know that. What's the workup preoperatively? And make sure that you document that you're going to follow the results so that you can make recommendations to your anesthesiologist. Anticoagulation recommendations. Do you guys have surgeons here that use aspirin for DVT prophylaxis for arthroplasty? It doesn't work. So the Crystal study just came out, and I didn't have time to put that on here, but Crystal came out and it doesn't work. There was EPCAT that came out earlier but that's different. So at any rate, anticoagulation recommendations. Stents. When was the stent placed? What type of stent? Can you take them off of dual antiplatelet therapy? Pacemakers and defibrillators are something that we oftentimes don't talk about in our comments. Is the patient pacer dependent? What happens if we put a magnet on them? What's the battery life? If the patient has a defibrillator, have they recently gotten shock therapy? That's a red flag for the anesthesiologist. Those are things that we in medicine can do to get our patients safely through surgery and to notify anesthesia. Recommendations on, again, blood disorders, and a lot of times we have to get our help from our hematology friends. Our diabetic patients, getting them under control, and what do we need to do to them on Dave's surgery? And then, of course, your own contact information so that the anesthesiologist can reach you from, the holding area and say, oh my God, I have a question for the. So at the end of the day, we're finished. We've talked about perioperative cardiac and pulmonary risk. I do recommend that you use the risk calculators because they're simple and they're easy to use and they're validated. I do suggest that you start thinking about using the DASI score because if I'm going to project, I think that the American College of Cardiology's next algorithm might use that. For cirrhosis, consider using vocal pen. For biomarkers and MINS is a thing. It's clearly a thing. And do use BNP's pre-op and troponins post-op, and have a high index of suspicion for MINS. Now you know what MINS is, and now you know that it's got bad outcomes. If you're interrupting the direct oral anticoagulants preoperatively, don't bridge with low molecular weight. And remember, your surgeons have quality metrics as well that they're following, just like we do. And again, think of anesthesia as your customer. And with that, I actually finished on time. Boom. And I hope that was worth your while. And I thank you guys so much for having me as your visiting professor these couple of days. And I'm happy to take your questions in the room. Thank you. Mm-hmm. 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 Sure. Mm-hmm. It's a great question. So the question from the room is, intraoperatively, first of all, the anesthesiologist is our customer, but they're our customers as well, right? And so, and we're their customers both ways. And so the question is for MINS, the events that occur intraoperatively, what is being done to look at that? So one of the things, I actually recently wrote a couple of book chapters with Stephen Cohn, which many of you know, in hospital medicine, who's the guru. And one of the things that I found in my due diligence is intraoperative hypotension. And so one of the things that we in medicine don't do very well is we don't look at the flow sheets when patients go to the OR. What were the vital signs in the OR? Did the patient get a lot of fluids or blood products? Did the patient drop their mean arterial pressure less than 65? And for how long? And if it's anything over 10 minutes, then there's a significant risk there for perioperative myocardial injury, whether it's MINS or whether it's a complete MI. So intraoperative tachycardias are also an issue because that's where you get into the supply-demand mismatch and the ischemia. So those are some areas that I think that need a bit more look in terms of the intraoperative piece. I think from the medicine point of view, at least we can sort of risk stratify them and sort of identify them preoperatively and have the index of suspicion to test them postoperatively. Because at the end of the day, we have to tell them, look, you're at risk. You know, yes, you didn't have a heart attack clearly, but you are at risk. So, but those intraoperative events are very important. Intraoperative tachycardias and intraoperative hypotension, and the duration of both are things that I've found. Good question. Any more questions? Yes. Uh-huh. I honestly, that's one of the because I sure as heck don't do that. So again, I'm not saying I agree with everything in there, but I'm simply presenting to you what is it that's being done that the surgeons are doing, right? I mean, again, the surgeons are giving their patients aspirin for DVT prophylaxis. So, you know, we all have our scope of practice and our differences of opinion. So, but that's what's being put out there. That's what's being put out there. Good question. Letting patients eat 2 hours before surgery. Any other questions? Any questions online? What about the pulmonary piece? So the question was, yeah. Now, my friend Dr. Yusuf over there is going to say, but if you're diagnosing MINS, that's going to prolong the length of stay, right? Because it's going to get more of a workup, right? That's what's going to happen, and that's the pushback I get from some of my colleagues. Is it is a patient safety, but again, some of the pushback I'm getting from some of my colleagues is, and this is a controversy with MINS, is that like, okay, if you do these screenings with the biomarkers, you don't have a clear-cut evidence-based treatment algorithm for them. And so you might be prolonging their length of stay, and should some of this be done in outpatient? Controversy for you. But yeah, the pre-op consult should address all chronic diseases. Most of the times we get called for the cardiac piece, right? So I would give an evidence-based risk assessment, whether you're using, now the myocardial arrest from Gupta only calculates myocardial arrest. And so that's why in perioperative spaces, that one doesn't get as much acceptance as the others that calculate major adverse cardiac events, which are fatal or non-fatal MI, angina, and CHF. And so those are really the more outcomes that are more common and more salvageable. Yeah. Good. Yes. So the question is, what are the best practices for hospital medicine in the perioperative space? We used to have a pre-op clinic where we had a really, we use in our electronic medical record, we had this great template with a smart phrase, and everybody had a revised cardiac risk index, and everybody had you had embedded in there that you could use revised cardiac risk index, the pulmonary piece, and also for atrial fibrillation, what's their CHA2DS2-VASc score, and what do you do with the blood thinners and so forth, and then recommendations on DVT prophylaxis. So having, and this is where if Dr. Rice is listening at the VA, he's really an expert on these templates, is having a standard template that everybody can use. You standardize your practice. Because it's important that everybody's doing the consistent thing as opposed to variations in practice. And that's from my QI piece. So yes, having a good template that has all this stuff on there. And we had that. We definitely had that. Stop bank score as well. We have the stop bank score on there. Perfect. Guys, thank you so much for having me here at USF. It's really great to meet you guys and see you guys, and I'm looking forward to the rest of the day. All right, cool.